Very excited to spend some time with Dr. Nima Salari. Dr. Solari is a orthopedic spine surgeon practicing at Desert Institute for Spine Care. And Dr. Solari is going to walk us through cervical disc replacement, what patients are maybe a good candidate for that procedure, and maybe what patients are not. So, Dr. Solari, why don't you start off by just introducing yourself and kind of tell us about your background, why you became a spine surgeon, where you did your training, and all that.
Yeah, I would love to. So last name, or my name's Nima Salari, obviously. Thanks for that. Thanks for the intro. I'm a practicing orthopedic spine surgeon. I've been here and practiced locally for almost a decade now. I kind of feel bad saying that, aging myself. But I first came to the Valley back in 2013 and joined the group and have been with the same group ever since. I finished my fellowship up at Stanford. Prior to that, I was doing my residency at Johns Hopkins in Baltimore. And I think that's a great question to ask a surgeon, how they became interested in kind of what they do and what they like to do. When I was first looking at schools and what I wanted to do, I was at the University of Pittsburgh for my undergrad, and it has a pretty good bioengineering program, and that's kind of what I enrolled at the time because I wasn't really quite sure what I wanted to do yet. I just knew it was something maybe medical, but not quite 100% sure, and so I thought engineering would be a good field to hop into. And as part of any undergraduate program, you get involved with some research projects, and the lab I worked with or in at that time happened to have a few of these robots, these big robot arms, and they would do big major biomechanical studies. They had also a good wing for some tissue engineering stuff. And it's if you know anything about the University of Pittsburgh or its orthopedic program, it's a big hub. It's a big attraction for obviously on a national level, but definitely also on the international level. And so where I was as a lowly, not even medical student yet, as an undergrad, there was a lot of fellows, foreign fellows there, also doing research in this lab. And so we had fellows from Japan, from Germany, parts of South America, and it was just a good group of guys and gals who were just in the realm of orthopedic surgery. Some of them more involved with sports than others, and I think that's kind of where I felt that orthopedic surgery would be kind of my next foray, and so I essentially pursued it. And when I got into medical school, I enjoyed my rotations in the surgical field. So again, that's kind of reinforced that for me. And when I was on the orthopedic rotation, I just knew this is kind of what I wanted to do. But then when I went to an orthopedic surgeon, I got accepted for residency. I still wasn't quite sure exactly what I would practice at the end of it. But spine surgery is just one of those fields where you're addressing pathologies in the neck, the lower back, the mid back. It's a broad range and wide range of types of surgeries that you do, the pathologies that patients present with. Even though we have a name for it and a diagnosis for it, every patient is different. There's always some form of a nuance to it. The way that you perform certain surgeries, you can certainly approach certain aspects of the spine from various approaches, from the front, from the side, from the back. In the cervical spine, usually just the front and the back. But just that, and then the other aspects of just the technology hadn't been it's still quite not there. We're still trying to really find the most optimal way to treat certain pathologies, and I still think that there's room to make those changes and those differences. And with my bioengineering background, and knowing that there's some technologies out there that we could still be kind of developing, that's kind of where I delved into it. And I think spine, again, for me has just been kind of that subject that has continued to interest me, obviously.
Yeah.
Ongoing.
Yeah, and talking about new technologies, in general orthopedics or kind of, patients are getting total knee replacements, hip replacements, whereas when you go into the spine, it's more common that you fuse the spine versus, doing a disc replacement.
Right.
And so that's what we're here to talk about today.
Absolutely.
So let's jump into it a little bit. I know you don't have any disclosures for this talk
No,
about
sir. No.
cervical disc replacement. Why don't you talk a little bit about what we're going to talk about today?
Yeah. We'll talk about, what is cervical disc or cervical disc pathology, who are patients who are identified to be ultimately surgical candidates, because obviously we try to employ all non-operative conservative measures first before we even consider surgical care. But then we'll talk about, why disc fusion versus a disc replacement. And like you said, just evolving technologies and, trying to move more towards motion preservation and tissue preservation, et cetera. I think, that's where disc replacements, especially in the cervical spine, come into major play.
And so what is cervical disc replacement?
Sure. It's a great question. Assume surgical candidate. Someone comes in with severe radiating symptoms down the arm, pressure on the nerve. They tried everything else, need surgery, right? It traditionally in the past, and the gold standard still to this day, is cervical fusion. We would perform surgery in order to, with the aim, obviously the goal being relief of pressure on that nerve structure or the spinal cord itself. And typically you address the pathology at the front or the back, as I said earlier. But usually, again, the front approach used to be the most elegant way to approach it. It's minimally invasive. You consider all the tissues that you have to kind of operate around that are very vital and but yet the approach is, again, very simple if you really try to break it down to the basic blocks of it. The approach itself involves removing the disc material, removing the offending agent that's on the nerve, maybe even removing a portion of bone, and typically then placing a bone graft or allograft there to then provide some structural stability, and then a plate and screws to really create rigidity, and then over time allowing the biology to essentially take over and fuse or unite these two bone elements that are normally not supposed to be united together. The idea of a disc replacement is essentially you perform those aspects of removing the offending agent, removing the disc, removing the bone spurs, anything that's pressing on that nerve, but then placing a device between the two vertebral segments or bone structures to then continue to do what the disc that was there before was doing, which is to maintain motion, preserve motion, allow for bending to either side, bending forward, backwards, and rotation. And the theory behind that is if you can preserve that motion there, that then you could hopefully prevent the segments above or below from becoming diseased, or at least reducing the speed with which that occurs. And for a long time, with all the variations of disc replacements that went on the market, some of the more latest technology, disc replacements, and some of the more latest results of those studies have actually shown that theory of preserving motion does indeed allow for reduced chance of requiring additional surgeries at the levels above and below. And that's kind of where that exciting factor is. Mm-hmm. Again, you're preserving motion, you're allowing the patient to the patient's body to maintain that same mobility, but yet at the same time likely providing them with the chance of avoiding hopefully surgeries again, future surgeries, because of segments above or below becoming symptomatic. Mm-hmm.
And you mentioned removing the offending agent. So what are sort of the common diagnoses or common diagnoses that you're going in there for?
Yeah, so we can certainly spend hours talking about all the different etiologies that could present, but I think the most common ones that patients present with are either herniated disc, herniated nucleus of the disc, or degenerative disc disease. I hate to say degenerative disc disease. I usually say degenerative disc changes because as we all age, the disc loses its hydration, loses its vitality in a sense, and just like we develop wrinkles or gray hairs, similar things happen to some of the joint structures in that regard. And you have this loss of height, and then you have resulting bone spur formation, et cetera, that then can result in narrowing in the areas where the nerve structures exit out. And as you can imagine, with a herniated disc, anything that it protrudes or extrudes or slips, in a sense, to use a more colloquial term, will cause at least some element of pressure in the area where it slips to.
Mm-hmm. And then how, this definition just, came online, but in your practice, what's the prevalence of people getting a herniated disc or developing degenerative disc disease?
I obviously I have to give you a biased answer on that because, it's a selection bias. We see patients who are ultimately symptomatic, and so it doesn't really apply to the whole general public. And so those numbers are pretty accurate in terms of the incidence of a herniated disc is about 5 to 20 cases per 1,000 adults. So it's relatively common. And so we see it commonly in certain age groups, obviously, but you could expect really to see that anywhere within the second to third decade to anywhere beyond that.
Mm-hmm.
So as the degenerative process kind of sets in as we all age, it's possible.
Yeah. And so why don't you talk through what exactly is a herniated disc and where is it happening in the neck?
Yeah, so that is a good image of the cervical spine. You can see the normal discs that are laid out. Essentially, they have a certain height to them. And then you can see as you kind of go down that image as Mike is pointing out, you can see some degeneration, loss of disc height. And then as the aging process occurs, there's definitely some osteophyte or bone spurs that form. The nucleus, I try to explain to patients, is more like the jelly inside of a jelly donut. So the rings around that nucleus essentially are part of the disc annulus or the disc covering, and they kind of keep that squishy middle part kind of intact. Now, if there's a disruption to that ring, there's a chance that disc or that jelly can then essentially slip or herniate out. And depending on where it herniates to, especially if it herniates into the area of the foramen that Mike is pointing out, that can then cause some pressure on that nerve structure that's exiting the spine and then cause symptoms down into the arm. And depending on the level that this occurs, it could certainly cause a different subset of symptoms. In fact, if we go to the next slide, you can see kind of the distribution. If you go to this slide exactly, you can see that distribution. And each nerve at each level then provides innervation to a certain dermatome and a myotome. Dermatome means more skin innervation, and then myotome means more kind of the muscle distribution. You can see that, certain patients will present with a C6 pattern pathology, for example, that will involve the thumb and the index predominantly, maybe involves their muscle, their bicep muscle, for example. Or if it's C5, it's more of the shoulder area and involves more the deltoid muscle. So based on that clinical presentation, we can generally know, where to look for the distinct pathology that's causing those acute types of symptoms.
Mm-hmm. And so with this radiculopathy, do some patients maybe go to a hand and wrist specialist or maybe a shoulder specialist thinking that it's their wrist that has an issue or their shoulder, not realizing that it's coming from the neck? Is that something you
Yeah, absolutely, 100%. And obviously, you want to be able to distinguish between the pathology and where it's occurring. But yeah, absolutely. And I think most distinctly, a lot of patients who have that pathology will have that pattern of nerve pattern start from the area of the neck with some potential pain symptoms that radiate along that distribution. And so that's where you start then distinguishing, is it truly just coming from the wrist? Is it a carpal tunnel issue? Is it a wrist issue? Is it a thumb issue? Or is it a shoulder issue? Is it a rotator cuff issue? Or is that just the nerve that's radiating? So yeah, you do need to see a specialist and then have some of the imaging studies along with obviously the exam and everything else to be able to then come to a diagnosis. But then once that diagnosis is established, that's where then, we then discuss treatment patterns,
mm-hmm.
et cetera.
And you mentioned as we age, our disc loses vitality and that can be an issue. So what are some maybe other risk factors to developing a herniated disc or degenerative disc disease? Is there anything we can do, lifestyle changes, to kind of slow that process?
Yeah, great question. Yeah, in fact, I think we just skipped over a slide. We don't have to go back to it, but obviously smoking is a big factor. There's definite studies that show a major link, and so even starting or stopping smoking within 6 weeks should reduce your chance of having an issue in that regard. Unfortunately, though, genetics play a certain role, or habits of activities and daily living certainly play a role as well. So in general, I try to recommend to my patients to stay active, have an exercise routine that they want to maintain, reduce the amount of weight they carry, and try to drink plenty of water and eat healthy, eat a broad, wide diet certainly you can look into a low inflammation type diet, but I think that's individual to each patient and outside of the scope of what I do. But I think all of that overall helps.
Mm-hmm.
Yeah.
And so when you are looking at, understanding or diagnosing whether or not somebody has one of these herniated discs or degenerative disc disease, how are you going through that diagnosis? What are you looking for? What studies and all that sort of stuff?
Yeah, no, excellent question. So usually the way things go, you see a patient who comes in with a complaint of pain in a certain pattern, certain distribution. It doesn't necessarily have to be just neck pain. It could be just arm symptoms, or it could also just present itself as a pattern of numbness or a pattern of tingling, pins and needles in a certain pattern down the arm. And so most often when we see the patient, they've been having symptoms for a number of days, maybe a number of weeks, and have had concerns. The most, obviously, the first step is to perform a physical exam. You want to look to see if they have any deficits of any sort, either sensory deficits or have any motor deficits, weakness in a certain pattern, any atrophy of any sorts that's visible, and then any other reflex changes, et cetera. So I think that has to be established first and foremost. And then after that, I think in terms of obtaining studies, typically we obtain x-rays of the cervical spine. Yeah, x-rays, the difference between that and, for example, an MRI is it gives you kind of more of a structural view of how the bones align with each other in the front plane, the side plane, and then if there are any major bone spurs that have grown. And then following that, the next step, the more sensitive study ultimately becomes an MRI or magnetic resonance imaging type study that gives you an idea of what the soft tissues look like. And you can see here on this image, obviously you can see an MRI of the cervical spine that's depicted, but you can see a portion of the brain stem, the brain, the spinal cord that passes and goes through the spinal canal. You see the bone structures that are in that light gray, and then the darker structures are the disc spaces. Each sequence in an MRI scan will give you different type of information, but you can see here, for example, at the C2, 3, 4, 5, 6, the C5, 6 level, there's actually an element of a disc protrusion. You would have to look at this from an axial perspective or different perspectives as well, but you can see that there's definitely some pathology that could potentially be causing some narrowing of not just the central canal, but potentially also the foramen or the area where the nerve structure exits the spine.
And then so going to that axial, what are you looking for here?
Yeah, so assume that that's at the C5, C6 level, and that's that herniation we just saw. By convention, if you're ever looking at an MRI, we're looking at the scan or those slices, those axial images that you have shown there from the bottom up, so from the feet up. So technically the right side of the screen will correspond to the left side of the body and vice versa. So in this setting, you can see, I call that the arrow sign because the radiologist put that arrow there. But you can see that there's definitely a herniation that we just kind of showed or went over on one of the other images. And that's actually pressing or displacing that exiting nerve structure at that disc level. And that most likely is causing this patient at least left-sided arm symptoms. And if, say, at the C5, 6 level, like I said earlier, it will involve maybe a pattern into the forearm, into the thumb, maybe in the index finger as well.
And so where do patients go from here? So
Sure.
Got the MRI, you see that herniation, conservative options.
Oh, 100%.
interventional? Yeah.
Yeah, absolutely. Unless something's been going on chronically and they've tried everything else, the first discussion we have is conservative care. Try everything we can to address the symptoms. So, first line of therapy is just non-invasive type things, medications. So anti-inflammatory medications like ibuprofen, Motrin, Aleve, those help reduce the inflammation that's associated with that disc herniation and tend to help with some neck pain symptoms, maybe even with some arm symptoms. In addition to that, you may consider something like gabapentin. It's a calcium channel blocker. It helps reduce the best way to describe it is like reducing the noise in the picture or the noise or signal in the nerve. And so that'll help reduce some of the pain symptoms down into the arm. An alternative to all of that as well would be like a steroid pack, an oral steroid taper. That again is a big anti-inflammatory type medication that then help reduce inflammatory changes again in that area. And then you can certainly also try muscle relaxers. Certainly any pressure on a nerve structure can cause spasm in the muscle, and that can cause pain symptoms. We try to employ narcotic medications very, very sparingly, but in a setting of really severe symptoms, narcotic medications can help. What they do is they essentially reduce your pain perception, if you will. In addition to that, heat or ice can sometimes help as well. Certainly that area, some heat generally tends to penetrate deeper, but ice can certainly help as well. And then rest or at least immobilization sometimes with a soft collar can help as well. If those don't work or they're not making improvements, then the next step would be considering at least some form of other modalities, including injections. In the interim, though, anywhere between the medications and the injections or acupuncture treatments to just help relax some of the muscle tissues. There's cupping, there's physical therapy, massage. All those are good and should certainly be trialed before saying, okay, that's not working for me, because again, each individual patient is going to be different. And then that's where you then go into more invasive treatments, including an injection.
So there's certainly, I would imagine every patient is scared or apprehensive of going through surgery, and so maybe they might just keep getting injections over time. Is there any issue to continuous injection therapy versus moving forward with surgery, or if it only works for a tiny amount of time?
I always tell patients, try injections for as long as they're working for you, and if you're getting good relief with the injection, weeks, months, that's perfect. Obviously, you want to always counsel the patient based on their presentation, and so if they present with major deficits, especially motor deficits, I'm a little bit more guarded in that recommendation. You don't want to have a major deficit present for a long period of time, because then the longer it's there, the higher the chance of it becoming more of a permanent issue. But so if injections are working, if the first injection or second injection, even the third or fourth injection are providing you with good relief, I don't think that there's any necessarily need to take that next step. But in general, most often patients, if they're going to find relief with an injection, they'll find that relief within the first, second, possibly even the third injection.
Okay, gotcha.
Yeah.
And so if that, like you're saying, if that doesn't provide relief, what are the surgical options?
Great. Yeah, so we talked about that earlier, but the surgical options obviously are multifold, depend on the pathology, and so not one treatment suits all type of approach, and hence why you have to have a conversation with your spine surgeon about that. But you can approach the cervical spine from the front, you can approach it from the back, and again, depending on the pathology, you try to provide the best option for that patient. We can briefly touch on the posterior cervical aspects, like just the laminal foraminotomy, where you just remove a portion of the facet and remove, essentially unroof the area where the nerve structure is exiting. But I think that, again, the most elegant approach is through an anterior approach, only because, again, it's less invasive. There's less or no muscle dissection, really. You're just going between planes of tissues to get to where you need to get to. That's where then either you discuss either an anterior cervical discectomy and a fusion, or an anterior cervical discectomy and a disc replacement. And that's where, again, you have to base it on the pathology the patient presents with, their underlying health issues and morphologies, et cetera.
And so why don't you walk us through an anterior cervical discectomy and fusion, and what patient would you choose for that versus a disc replacement?
Yeah, so in this patient, obviously because you're approaching the spine through the front, the patient is in a supine position or lying on their back. You make an incision on the skin. That first layer of tissue that you saw was the platysma muscle, so you split that, and essentially you gain access between the sternocleidomastoid and the more central structures, and you find that plane of tissue and essentially just push everything aside once you get past that first layer. And here you can see the disc was removed, and then a bone dowel was placed, and over that bone dowel is a plate and screws. The plate and screws provide the stability and rigidity and prevent the graft from kicking out in the front, and also reduces the chance of a subsidence, but then over time then allows the body to go ahead and fuse that segment and obtain a solid fusion. I'm sorry, I think that answers that question for ACDF.
And so where are you performing an ACDF procedure? Sure. Hospital, surgery center, one or the other?
I think any setting is an appropriate setting for the appropriate patient. So we can get into the criteria of how to choose and select patients, but I think either setting is very safe and very suitable. I think in this day and age, plenty of studies that support 1 or 2 level anterior cervical discectomies outpatient and going home the same day, either from a hospital or a surgery center. But again, we have to get into the nuances of the patient's health metrics and other matters as well as to kind of where they're more suitable to. And that's where the decision has to be made between the surgeon and the patient.
And then what's a recovery time frame? What are, I guess, some of your recommendations for maybe speeding up recovery after an ACDF surgery?
Yeah, so for an ACDF, again, we're talking about a fusion here. Most often, patients are going to require a cervical collar or rigid collar on top of the internal rigid plate and screws that they've had. It just provides this additional level of rigidity on the outside to then allow the body to go ahead and fuse that segment for that biology to ultimately work. So there's that aspect of it. So with a fusion, cervical collar is typically necessary. And then it's supposed to, again, limit your head and neck range of motion for a period of time to then allow for the bone structures to heal together. And I think that's one of the downsides of a cervical discectomy and fusion. In terms of post-op recovery, patients will have at least some elements of neck pain in the front of the neck and the back of the neck just because of the way that they're positioned to have their pathology addressed. They might have some hoarseness, some swallowing trouble, and then maybe still some residual symptoms, or those residual symptoms may present themselves several days after because that nerve is always going to be irritated, at least in the initial post-op period. And then there's always that element of swelling as well. But usually by 2 weeks when I see patients back, I think they're pretty surprised as to how well they're doing and how limited their pain is and how minimal their pain medication requirements are.
So switching gears, looking at cervical disc replacement versus ACDF, what patients fit the criteria for artificial disc replacement compared to ACDF?
Sure. We talked about the pathology specifically, and I think a disc herniation, for example, is a prime example where I think most patients would have to consider between that versus a disc replacement. Someone who has a supple disc, who has a disc herniation there. But if you really dig deep into some of the criteria for a disc replacement, you still want to have at least some element of residual motion, for example, at that segment. If it's like a segment that's been collapsed for a long time and has had no motion to it, there's no good indication to try to restore motion to that segment. Someone who has really bad or significant arthritic changes or breakdown of the joint structures in the back of the neck, preserving range of motion for that will cause them to have continued or ongoing pain symptoms. And then you also want to look at the cervical alignment of the neck itself. You want to have someone who has, at least within normal limit alignment. If someone has a neck that has more of a forward pitch to it, you do have some concerns about disc replacement in that regard. But I would say age is not necessarily a factor. Certainly you want to evaluate each patient and each individual pathology that they present with, and some arthritic changes are still going to be okay. So I think in the traditional sense of a disc replacement, I think those relative contraindications are a lot less limiting, and the technology, as we talked about with the disc replacements and some of the more latest technologies and the disc replacements have allowed us to broaden that indication for patients. But so ultimately, if anyone has been recommended to have a disc a fusion in their cervical spine, should at least consider consulting with someone who does disc replacements to see whether they are a candidate possibly for a disc replacement as opposed to a fusion.
Mm-hmm. So when you're assessing the neck, are you doing that 100% through imaging, X-ray and MRI, or are you doing any lab work to look at, osteoporosis or anything else? Or
so imaging study for osteoporosis is definitely critical. There's no lab work necessarily that we employ for that, but anyone with osteoporosis is likely not a good candidate for a disc replacement. But outside of that, it's obviously physical exam, range of motion examination on the physical exam, but then yes, also then reviewing flexion extension X-rays on the cervical spine, reviewing the MRI, and ultimately also assessing kind of what the patient's needs are and what the patient's goals are in terms of where they want to be and how they want their recovery to go.
Mm-hmm. And so why don't you walk us through the procedure, similar approach, but different implant?
Yeah, exactly. So similar approach. Again, the patient is going to be in the supine position, so lying on their back because we're going to try and get access to the front of the disc. Looks like here the video is going to show access to a C4, C5 disc herniation. And essentially, again, make an incision, go along or between a plane of tissues. Again, you're not really cutting it really into anything outside of the skin. And then you remove the diseased disc and the offending agent, and essentially just prepare the end plates without shaving the end plates in any way. Now, this video is a little bit more invasive than we usually do. We just essentially just are able to scrape the discs. This particular disc replacement itself, I don't utilize, but again, most disc replacements will function in a very similar pattern in terms of essentially just preparing the disc and then placing a device such as this that then sits there with no plates in the front. And here's a comparison between a fusion. So again, you can see the plate and the rigidity that it creates, but versus a disc replacement that then is allowing still for range of motion. And it's believed that preservation of range of motion at that segment then reduces the chance of an adjacent segment seeing more of those biomechanical forces and reducing the chance of that segment becoming more symptomatic.
Yeah. And then here's a look on X-ray. What would you point out here on an X-ray with a disc replacement compared to maybe a fusion with a plate?
You can see the device and the position it's in, the fish mouthing in the front, showing that it's preserving at least some lordosis or some alignment to that segment. And you can see on some of the follow-up X-rays, including the flexion extension X-rays, that you can see that fish mouthing in the front goes away a little bit, and you can see in the back it opens up, so you can see that there's some range of motion. You can see the splaying between the two spinous processes in the back, so that's preserved there. Just that comparison, you can see that it acts very much like the other discs that are part of the native disc that is already there.
Mm-hmm. And then here's a sort of dynamic X-ray.
Right, and you can see the splaying in the back of the spinous process in the back, so that's kind of where you see the greatest motion. But then, you can see when you extend how it fish mouths in the front. So you can see that there's still much motion preserved because of the disc replacement that's there.
And then talking about recovery after a disc replacement, how does that compare to an ACDF?
Sure. After a disc replacement, there's no cervical collar. There's no rigid collar of any sorts. In fact, we encourage patients to get back to normal activity. The upright activity and mobility movement allows that disc replacement device to kind of settle in. The material that these disc replacement devices are made of is, at least they have some form of a metal end plate these days. And that metal end plate is a titanium with rough coating so that it grows essentially into the bone. And so part of the biomechanics that's required for that ingrowth is activity where essentially you are loading that. And so we encourage patients to get back to those work activities. And so a lot of times for a disc replacement, I have a lot less restrictions for my patients, and I'm asked them to go back to work or whatever other activities they're performing relatively early on. There's very little downtime as a result of it.
What are some of the common questions that patients have after either ACDF or disc replacement in terms of when I can get back to? Imagine you have a lot of golfers that you treat. So, how would you compare the recovery ACDF disc replacement for a golfer?
Yeah, I mean, obviously, theory and practice or the practicality of it kind of meet. The patients are able to just go back much earlier with a disc replacement as opposed to a fusion, because there's no restrictions in their range of motion in the neck. In fact, they encourage them to do that. And so, as opposed to someone with a rigid collar, and a lot of times I'll ask, when can I drive? I can't look over my shoulder because of the collar, and that's valid. That's a valid concern, because we do want it to limit their range of motion. They have that concern about turning their neck too much. So much faster recovery, much faster return to normal activities with a disc replacement. Another thing is, a lot of times when you place a patient in a collar, just like you put someone in a wrist guard or a cast for the wrist, it takes a while to regain that range of motion, partly because of fear of hurting yourself further or something else. And that's where, again, with a fusion surgery, you kind of see that more, where patients are a little bit more apprehensive about moving their head and neck as they would kind of in a normal manner, at least in the initial couple of months, whereas you don't see that at all with a disc replacement patient.
And so having surgery is a life event, right, for anyone. And so what would you maybe say to a patient out there that's been told you need an ACDF, or maybe you need a cervical disc replacement? What would you tell that patient? How would you tell them to maybe research the surgeon that they're maybe considering, and why would a patient maybe consider you, Dr. Solari, as their surgeon?
Great question. I always, anytime I see a patient, I tell them, if they wish, they should get additional opinions about it. Like you said, it's a big, major life event. And so you want to ask as many questions about the surgery. You want to have as great of an understanding of the risks involved and the potential benefits. You want to be able to make an informed decision. And so if it takes you multiple visits with the same surgeon, if it takes you multiple visits with several different surgeons, I think everyone should take that time to do that. In cases where they present with a major deficits of sorts, maybe that time is a little bit more limited, but they should be able to get in and speak to someone, especially their surgeon, before surgery. So I really think it's important that they have that discussion, that conversation with their surgeon, and ultimately just feel comfortable. Feel comfortable asking questions. Feel comfortable with the answers that they're getting, and it should never be an unknown going into it. So that aspect, like you said, there's a lot of really good resources online where patients can educate themselves. In fact, our website, if they go to www.sciatica.com, there's plenty of videos, plenty of blog posts and articles about that. So the information is out there if you're looking for it. Even on YouTube, you can find videos of the actual surgery itself. Sometimes gory, sometimes not so much. So definitely inform yourself. And then in terms of choosing a surgeon, again, it's a comfort level. If there's a recommendation made by your primary care physician or by your pain management doctor, certainly follow that recommendation. But just know that you can also get additional opinions elsewhere. You can always call up your insurance company and find who's in network with you. So all that information is certainly also attainable. And then researching a surgeon, you can go online. There's the resources there. You can just simply Google someone's name. That's one way to find someone. But again, I think ultimately once you've found the 2 or 3 or 4 surgeons that you've had interviews with, it's ultimately who you're most comfortable with. I think that really comes down to that. Whatever rapport you have with them when you're having a conversation with them. You can always ask family and friends who they've seen, etc. So. Luckily, we are in an area here in Phoenix where we have very good, very reputable surgeons in all practices, either neurosurgeons or orthopedic spine surgeons. And so I think it's ultimately who they feel most comfortable with.
Yeah. And you mentioned insurance coverage, and that's one thing I'd like to talk about too. So how does insurance coverage play a role in ACDF versus disc replacement? Is insurance covering disc replacement?
No, that's an excellent question, actually. With some of the more recent, really high quality information and data that came out just a couple of years ago, where there was actually there was a study or two that showed that a 2-level disc replacement is actually superior, which was, again, before that was what we were trying to show. It was superior to 2-level disc fusion. And so I think that's, in the previous years, as these disc replacements were coming out, I think some of the private insurance companies were a little more hesitant in covering those. But in fact, now that has completely shifted to the other end, where I think they're more encouraging, actually, of a disc replacement or motion preservation, mainly because they see the data and they see that the reoperation rates are lower. They see that the outcomes can potentially be more of benefit to patients. And so I think for anything 1 or 2 level pathology, that's what the FDA approval is for, 1 or 2 level discs. I think in this day and age, I think any patient can, again, be able to get coverage for a disc replacement if that's what the best option is for them.
That's great. So people can go to www.sciatica.com to find you.
Yes, sir.
Dr. Solari, it was a pleasure speaking with you today. I appreciate you coming down.
Thanks for taking the time, Mike. I appreciate you.